listening to me about a journey about a laser, a femtosecond laser by Schwind that started in about 2019 and how it has taken big turns over the time. So again, there's certain parts of things which I did discuss yesterday. And I'll be discussing the same thing again. Now, what I'm trying to tell you is, what are we, I think most of you all are doing refractive surgery over here. So what are we really want, and what do we understand on refractive surgery now? So most refractive surgeons now, we understand what is customized treatments, which was not possible about 20 years back. Half of us had not understood what high order aberrations were, coma or spherical aberration, what trefoil was or what quadrifoil was. So now with the advent of new scanners and aberrometers, we do understand a lot and understand what customized treatments are. So in refractive surgery, we have to understand the most thing that we want is customized treatment. Every eye has to be treated customized way. So we all want to give to our patients our best, the best to our patient. We want stronger corneas, we want less dry eye, we want the smoothest and the best results. So I want to talk to you a little bit over the past 5 years, what this ATOS has done. The prototype was in my clinic and we did all the clinical trials and how it started and where it is heading to. So half of it, I have talked about it yesterday and probably a little bit more on to see what is going to happen in the next 2 years. So when we started the lenticules, the first thing we really wanted to do was to see whether the lenticule was working or not, whether the corrections were accurate or not. So the only thing that we were actually looking at was the lower order aberrations, and we were comparing it with other lasers. So we were comparing it with the Visumax, which was the mother femtosecond, and we were comparing it with the Zemer or whatever, and we were saying, yes, it is working, it is working. Till we started comparing it, and we called it Smart Sight, till we started comparing it with excimer lasers, we realized that the treatments with femtosecond lasers are not very good. It was not very adequate, the patients are not very happy. Though we knew it was working, like we were using the Visumax for the past 10 years, and you know, the results that we are getting with the ATOS were same. And again and again, I keep telling, yesterday also I said the same thing, with the femtoseconds laser will not replace the excimer laser, will not replace even the microkeratome because they cannot do customized treatments, you cannot do topo-guided treatments, you cannot only treat lower order aberrations, you cannot treat the high order aberrations, and you cannot treat on scarred corneas. But this is a concept till we did yesterday, and I have few more slides from yesterday which will tell us how the femtosecond is going to replace the excimer laser. Try. So I'll talk mainly on the ATOS now. So the ATOS, the laser itself is a very high frequency laser. It's about 4 megahertz, very high speed, excellent resolution, and quasi-telecentric optic. Now what you have to understand this slide is, when you talk about speed, I've seen the ATOS make a lenticule in 6 seconds. It can make a lenticule in 6 seconds. But speed is not what you want from any laser. What you really want is excellent results and patients being happy. The speed is dangerous. The second thing is excellent resolution and all that is there, but the quasi-telecentric optics. So the whole laser has changed the optical system. The quasi-telecentric optic means the scanner spins, it goes very down close to the cornea, and it is firing perpendicularly to the cornea. So it's not firing from the top, and there's no reflection in the periphery. So if you get reflections in the periphery, the energy in the periphery becomes very low and the cutting quality is different. In the center and in the periphery, you have different cutting qualities. So with the quasi-telecentric optic, the cutting quality is the same in the center as well as in the periphery. So you will not get lenticular tears or lenticular tags. The lenticule will not tear. The laser itself, over time and time, fighting with eyes and all that, what we really didn't have was the eye tracker, cyclotorsion, and finally we had the eye tracking system, and we had the cyclotorsion with pupil recognition, with treatment offset, and we thought, yes, what we didn't have, now we have it, and we get great results. But that was not it. So what we actually had, there are certain lines you have to understand is the eye tracking guided centration and docking provides a robust, accurate, and precise alignment of the eye to the system. So the alignment of the system to the eye means the treatment packs are curved. So when the treatment packs, they go and fit on the cornea, they don't actually deform the cornea, they don't flatten, or the deformation of the cornea is not too much, because the vertex can really move away from this, and then you can have decentration, things like that. The second thing we have over here, the asymmetric transition zone concept provides a robust, accurate, and a precise alignment of the lenticule to the eye. Now this is a transition in cases of angle kappa, when your treatment lenticule is away from the center of the pupil. What it means is the lenticule is not circular. It means the lenticule is oval. It's trying to cover up for the edge glare, which I will show to you again. So what was actually happening was we were getting great centration with good cyclotorsion, and then the lenticule was also trying to be shaped in a way that is going to be more and more customized. So with good centration, what you're really looking at over here, what I'm trying to show you is called mud cracking. So when the lenticule is not aligned with the corneal vertex, the whole cornea is going to be crumpled. It's called mud cracking. So when you get mud cracking, there's going to be a lot of scatter, you induce coma, and there's going to be undercorrection. So the first thing we thought was, okay, with good centration, we do not have mud cracking and no induction of coma. And this is the asymmetric transition zone concept. So what happens over here is, if your visual axis is not in the center, it is inferior nasal, so the whole lenticule will be shifted inferior nasally. But then over here, you have what is called, and the pupil will dilate at night, night vision issues, you will get an edge glare. So the lenticule itself is shaped asymmetric transition so that the patient does not get edge glare. So now, this is a few more steps closer to getting more and more customized, into customized treatment. The lenticules, one step more into customized treatment. But then what? Again, we realized, could I have the slides? The lenticules, they were shaped differently. So what's actually happening over here? Differently shaped lenticules. The upper cut of the lenticule was not parallel to the surface of the cornea. They're steeper over here. And in the edge, it goes down over here. You see, it goes really down to 0 microns with a very, very large transition zone. So what's actually happening is the periphery is getting very smooth. So the epithelial remodeling is very little. And with the steep cornea over here, I mean the steep lenticule, the amount of tissue that you're taking up is very, very little compared to what you're actually using up with Visumax or any other laser. The lenticule edge design with the atosovia is so important that the epithelial remodeling, which is giving most of the regression, came down. So the power that you're expecting to undercorrect or overcorrect and thinking it'll regress, it doesn't happen with this. The lenticule goes right up to 0 microns, and sometimes you think the lenticules, they usually have a minimal thickness of about 10 microns with the Visumax. Some will have some amount of This goes right down to 0 microns. And so there is no side cut. So if you don't have a side cut, the lenticules are not sticky at the edge. So side cut is one of the things we realized was making the lenticule more sticky. So with removing the side cut, the lenticules are much, much easier to dissect. Secondly, the large optical zones. So even if the transition zone is so large, about 0.8 compared to 0.1 with other lasers, this 0.8 transition makes the optical zone much, much bigger. But sometimes saving tissue can be very, very tricky for very low myopia, like, for -1 or even -0.75. You can't treat it. You cannot add tissue and make the lenticule very thick. So I always recommend people not to go below 30 microns. So if you go below 30 microns, you might land up with different planes. So this is a nomogram. This is just not a nomogram. This is just the amount of tissue that can be taken out. If you look at it, it saves a lot of tissue over there, especially very important for high myopias. The laser excellence is an in to outbound. You've always seen that the laser is coming from outside to inside, but this is from inside to outside, in the sense that when the patient is fidgety, most of the time when the patients are moving their eyes, that is at the end of the treatment. So during the end of the treatment, if they're moving their eyes, you don't get slithers. If the patient moves, the slithers are always in the periphery, not in the center. So that way, the moment you move your eye, it's usually at the end. You can get a big black spot in the center of the pupil. Okay, so that is avoided now. It's always in the periphery. So with all that, so we had good eye tracking, we had a great lenticule, we had all that, and then we realized the refraction was the same. We were still not getting what we wanted. The wow factor was missing. So, it was jaisa tha, waise tha, kya change hua? Like we got the eye tracker, we got the cyclotorsion, we got everything. And the lenticule is also a little bit more differently shaped and everything, and the result is the same. At the end of the day, the patient, before they leave, they just would say, "Are saab, mera vision kab aayega?" Then we realized the only thing that we could do was play around with the energy. The only thing left was to play around with the energy. So it took us 1 year to play around with this energy. So starting with 120 nanojoules, you just cannot reduce the energy. Otherwise, if you reduce, it becomes too sticky. So we had to play around with the spot and the track distances, and it took us almost 1 year to go down from 120 nanojoules to 75, and then we do surgery mostly 80 or 85. We were so happy when we managed to reduce the spot distance and reduce the pulse energy, do good dissection, but again the result was the same. Okay? Energy bahut ghataya, wow, we reduced, we managed to do surgery at 80, but same results. This is what I'm trying to show you. We went from 120 to 85 and spot and track distance. What we didn't realize, hum log ko kya pata nahi chal raha tha, was why is the vision not coming? Like what was happening? Like, you've come down, the planes were smoother. If you take a paramis and see the retroreflection, it was so much smoother, but still the results weren't great. So this is what we did. And if you look at the post-op results, you look at the scans, they're very well centered. You could get, with correction, you could achieve 20/20, but this is back in 2019. The results were great, you could see, but from the patient's perspective, the results weren't great enough. The patients always complain, where when is my vision going to come back? So these were some of the results long time back. Then we realized that it is not the pulse energy that really is affecting. Then we thought we'd look into something else. So this is something I shared yesterday also. This is the formula. And then we realized there's something called as dose and power. So dose, this is the formula everybody should understand if you're using a femtosecond laser. The amount of dose that we're using was 750. So with the VisuMax it's the same. Then we realized that with some lasers they're using 2,500. They didn't understand. They're doing so low pulse energy. We are doing at 60, but still our vision is like 2040, best correct. What's happening? The silk is saying something, Zimmer is saying something. Then we realized something like the phaco power and phaco time. They're two different things. The total amount of energy that you're putting into the cornea had to change. So this is what I'm trying to show you is, even if you reduce the pulse energy to 60, but you don't know how to play around with your spot and track distance, you'll end up giving more energy into the cornea and your vision becomes poorer. So what? So this is what we are playing around. We reduced to 80 nanojoules, but then the total energy was again 750. Then we started playing around with the spot and track distance again. From there, went right down over here. This is around 450 over here. So this is how we played it. Cannot be seen very well over here. And then we did a study where we took up patients with low energy asymmetric spacing. The energy in the sense, the dose. And then we compared it with the ones that were having the normal energy. And then so this is where I work right now, 80 nanojoules. So the energy is always 80, but the pulse and the track, they're changing on every patient. Okay, so this is the current setting now. And then when you look at the energy, it's about 440 now, from 750. So from 750, we realized we've gone to 440. And then this made all the difference. This made the real difference, the dose. And immediately you can look at the post-op corneal the topographies, nice and well centered. They look a little oval. This is because of the asymmetric transition. And the results were great. And we've also done a study with LASIK in one eye and SmartSight on the other with very low energy. We have a group of which there are some surgeons who are doing under 400 nanojoules, but I'm not in that group. So that means there are surgeons who are doing like really low. And this was also published in the results, which we'll show you again. I showed this video yesterday also, how eye tracking, I don't know if you've seen this video, I'm not going to show it. Have you seen this yesterday? Okay, we'll just skip this video out. So sorry? You want to see the thing? So I'll show it to you. So when it is yellow or red, it means it's very far away from the visual axis. When it's green, can you show us the screen again? So when it's green means you're very close. The green circle is about, over here is about 200 microns. So within that green circle means that you don't induce too much of coma. The most important thing over here is the cyclotorsion. So on the table, the patient's eye can rotate if they are relaxed or if they are tensed. It can rotate up to 20 degrees, we have seen. So this is without docking. It's so important, and this laser is so easy. All you have to do is take the two crosses and align it on top of each other. The moment you align that, you're on the dot with great cyclotorsion. So on the interim then, the results started coming out much better. Semi-automated centration with cyclotorsion, with astigmatism going up to 6 diopters, successfully treating. lenticules as well as flaps. So the epithelium also, like the epithelium remodeling, which used to take up to 3 months, now they stabilize in 1 week. So after 1 week, most of the regressions don't happen. That's because the periphery is very smooth. The remodeling of the epithelium is very stable after 1 week. So 6 microns is almost about 0.5 diopters or something like that. So if you are comparing with the epithelial remodeling with other lasers, it's actually the Visumax and the Atos I'm comparing it. So the results after that, immediately, if you want to continue, this is something I showed yesterday. Most of our patients were within, 92% of the patients were within 2020 day 1, 42% of the patients 2016 day 1 post-op, which is again great results for a femto laser. Compared to, again, we are struggling with 82% of patients 2020 in 1 week. So this is back in 2022 and 2024, this is a big jump. And even we see over here, 40% of the patients gained 1 line, day 1. Low energies, asymmetric spacing. We see that 44%, sorry. Okay, let's skip this. When you compare the two groups, they're actually very, very accurate. Like the laser-wise, the femtosecond laser is not affected with, again, as I said, altitude, temperature, all those things, or alcohol, or perfume, or anything. So they were very accurately treating both the groups. But the amount of swelling that was being created by high energy has come down. Even the astigmatism there, if you look at it, most of them are within 0.5 diopters in day 1 already itself. So if you look at that, 100% of them within 0.5 diopters, day 1 post-op. Okay, let's skip all these. So I hope you understood this. So let's skip, I'm going to skip. Since we are out of time, 2 o'clock, I think another session has to start. So then I showed this slide yesterday also. The 86 parameters that we're looking into. So many things that usually that affect visual acuity. We realize most of the parameters are laser related. So the biological factors, that is the refractive error, age, gender, all that, they're all important, but the most important thing is the energy, dose, all those things. So I played this slide yesterday, so what I'm trying to tell you is younger patients do very well, experienced surgeons do better than the learning curve, spherical equivalent, lower prescriptions, you get good results, but a higher prescription you tend to gain more line because of the minification factor. Cylindrical powers, the higher cylindrical powers do worse, lesser cylindrical powers do better because of the optics. The target refraction, the amount of accommodation they have, they do better. Keratometry, steeper corneas do worse, flatter corneas do better because of the corneal deformation that happens with the treatment packs. And on the laser side, large optical zones, laser energy, like more energy, bad results, low energy, great results. Let's not talk on the spot and track distance. I think you'll not understand it too much. We'll leave it there. So again, looking at the whole thing, the most of the factors that really affect day 1 vision is the laser factors more than the biological factors. The patient factors, more than the patient factors, it is the surgical skills as well as the energies on the cornea. So let me skip this out. Again, I'm trying to tell you that things are moving better and better and better. I've showed this, I think everybody knows this video. Let me cut it out because we started late. So where are we heading to? So these are the slides. This is the slide I didn't show yesterday. So where is femtosecond laser? The one good thing what I'm trying to tell you, I'm talking about the Atos, the Schwind. If one laser goes into one direction, all the lasers are forced to go into the same direction. So today one laser is doing good in one direction, all the lasers will be really forced to go into that. So the step plan for Atos now is Femto trans PRK. This is the next step. Can you do a PRK with a Femto? So that is simple astigmatism. So most of the times you cannot treat simple astigmatism with femtosecond laser. You have to have a prescription, minus 0.5. You cannot treat 0 and a minus 5 cylinder. So you should have minus 0.5. Like the excimer laser is very simple. So now the next thing that is coming up is simple. Pockets by, for rings for keratoconus. Flex is something that had already died out. I think they want to do it again because it has some advantages. Flex is doing a kind of a LASIK with a lenticule with a flap on it. Okay? So sometimes you can add tissues, you can remove tissues, so many things. Circle means cap to flap. Like, you can convert a cap into a flap. All those are there. It is already there with the laser. So this is what is going to happen next year. The asymmetric transition zone is going to get better and better. Myopic mixed astigmatisms and a lot of customized treatments going to happen. Aspheric corrections, customized and all that. And PTK. PTK is very difficult with femtosecond laser, but still they're going to work on the laser energies as good as like the cataract energy levels. By 2026, this is 24, 25, and 26. Most of the things, for example, if you look at this hyperopic and presbyopic treatments, lenticule rotation, IOL calculation, this is already ready. So in 2026, what we are planning to release in 2026 is actually already ready. It's just that step by step we're going to release it. So this is where, so if you have all these, where you can do femto PRK, where you can do so many things, there's probably a femto might replace the excimer laser by about 95%. The excimer laser will still not be removed 100%. I think I will stop there. Thank you so much. I'm really sorry I disturbed your lunch, but then I was just trying to show you the last slide where the lenticular extraction is heading to. So probably by 2026, all your laser companies will be having all the features of your excimer laser. The femtos will have. If one laser company will have it, all the laser companies will be forced to have it. Thank you so much.